Hello everyone, I am Dr. Sapkal here. The title for discussion today is Mechanism of Labor. Ideally, it is a topic for practical discussion. We will try to explain theory point of view also and practical point of view also. First, you pay your attention over this dummy. Okay? We are going to describe the labor in vertex presentation. That is the commonest position. Vertex left occipital anterior position is the commonest. Now, how do you describe this position? What is position we will understand. Okay? This pelvis we divide into 8 parts broadly by 2 oblique diameters on either side, and this is anterior posterior diameter and this one is the transverse diameter. As such, this pelvis has been divided into 8 different parts. Whenever occiput is placed anterior portion of the pelvis, that is anterior position. When occiput is placed posterior to this pelvis, posterior part to this transverse diameter, it is posterior position. Okay? So, according to this, vertex left occipital anterior position will be like this. It will be here on the pelvic brain and the vertex is a well flexed head. So, vertex left occipital anterior. In the examination, you are asked hold the fetus in VLOA position, that is vertex left occipital anterior position. They may say hold it in LOA position. So, it is same, it is V1 position, VROA is V2. This is vertex right occipital anterior, this is vertex right occipital posterior and this will be vertex left occipital posterior. Like that, this will be vertex left occipital transverse. Most common transverse position is left side and most common posterior position is right side. So, this is vertex right occipital posterior. So, well flexed head is a vertex presentation. What do you understand by vertex? It is an area bounded by, this is the whole area which is bounded by posterior fontanelle posteriorly, anterior fontanelle anteriorly and 2 parietal eminences on either side. So, it is this whole area which is in relation with the lower uterine segment or external os. So, that is vertex presentation. So, this one will be vertex presentation. Now, we will try to understand the meaning of each term which is used in the mechanism of labor. Okay? What is denominator? Denominator is a fixed point on the presenting part. This term is given to describe 4 different positions or 6 different positions in relation to the pelvic brain. So, in vertex presentation, what is the denominator? Occiput is the denominator. In relation to occiput, I will describe the positions VLOA, VROA like this, VROP, VLOP, VLOT and VROT. So, these are the different positions which are described in relation to occiput. So, occiput is a denominator, but remember in vertex presentation occiput is also a leading part. Leading part is the part which first touches the pelvic floor during labor. So, now suppose it is like this. So, it is the leading, what is the leading part in vertex presentation? It is occiput. It is touching the pelvic floor. Sinciput is at a higher level like this. Suppose it is a well flexed head, which pole is down? Occiput is down. This pole is up. So, occiput will first touch the pelvic floor in second stage of labor. So, what is the leading part in vertex presentation? Occiput. What is the leading part in face presentation? Mentum. What is the leading part in breech presentation is different. In breech presentation, the leading part is anterior hip, but denominator is sacrum. In vertex presentation, denominator is occiput and leading part is also occiput. In face presentation, denominator is mentum and leading part is also mentum. So, that is the difference between the leading part and the denominator. Okay. Now, the next thing which you try to understand is this movement of the head is flexion, increase of flexion. Normal attitude of the fetus in the uterine cavity is of universal flexion. So, this one is, this movement is of increase of flexion, so that this chin touches the sternum. So, this is increase of flexion. This movement of the fetal head is extension. So, head is borne by the movement of extension. This movement of the fetal head is extension. So, occiput fixes below the pubic symphysis and it is borne out by the movement of extension. This movement is flexion. Now, the second terminology which is used is internal rotation. So, this one is the midline diameter, okay. This one is the midline diameter, this is the oblique diameter. In vertex presentation, vertex left occiput or anterior position, the occiput is in relation with the left iliopectineal eminence. From this oblique diameter, whenever the occiput moves towards the midline through 1/8 of a circle is internal rotation. Now, once it gets borne out, when this occiput moves away from the midline is external rotation. Understood? So, let us clear it again. What is internal rotation? When occiput moves from here to here is internal rotation. When occiput after birth, when it rotates from midline to external, outside, near the oblique diameter, and it is external rotation. Okay, understood? No problem. Now, let us discuss the steps in the mechanism of labor. Can we focus here? In these cases, I have written here, we are describing the mechanism of labor. What is mechanism? It is the way by which the fetus adjusts itself to the pelvic passages, to these pelvic passages and short passages also, means pelvic floor, vagina, introitus, like that. So, it is the way by which the fetal head and the body also adjusts itself to the pelvic passages while coming out of the introitus during labor. That is the mechanism. So, let us try to understand what is the mechanism of labor in vertex presentation. We know the leading part in vertex presentation is occiput. What is the denominator? Denominator is occiput. Okay. In vertex left occiputo anterior. This is the anterior position which is commonest in anterior. VROA is second common among the anterior position. So, occiput is here. This is the fetal skull I have drawn here. This is the fetal skull. This is the occiput and this is the sinciput. Okay. This is the pelvis. This is the sacral promontory. The diameter, the oblique diameter which starts from right sacroiliac joint is right oblique. So, this diameter is right oblique diameter. The one which starts from left sacroiliac joint is left oblique. So, this one is the left oblique diameter. Okay. So, oblique diameter, no confusion. The one which starts from the joint, right side, right oblique. Left sacroiliac joint, left oblique. Okay. Understood? So, here is the occiput initially. Now, what happens in vertex left occipital anterior position is occiput rotates from this position to midline. That is the principle. So, in internal rotation, it moves towards the midline, that is 1/8 of a circle. This is how the things go on. Now, let us learn this thing in steps. I have written here, descent is occurring throughout the labor. So, this is the descent of the fetal head. It is occurring throughout. So, all movements are overlapping. There is no clear cut landmark in between these movements. So, the first movement or the descent, you remember descent is occurring throughout the labor. First movement is increase of flexion and engagement. Now, come here. Now, we will learn it on the pelvis. What is this? Increase of flexion and engagement. When the chin touches the sternum, it is well flexed. This is how it is well flexed. Now, in cases of vertex presentation, when it is well flexed, the diameter of engagement is suboccipitobregmatic, like this, highest point of vertex. So, it is from here to here. Suboccipitobregmatic is the diameter of engagement when it is a well flexed head. If the head is deflexed like this, little bit more, then the diameter of engagement is again starts from subocciput, but frontal is the anterior margin of the anterior fontanelle. This is the anterior margin of the anterior fontanelle up to here. So, in deflexed head, this suboccipitofrontal diameter is 10 centimeter, well flexed head suboccipitobregmatic diameter is 9.5 centimeter. So, these are the vertical diameters of engagement according to the degree of the flexion of the head. The transverse diameter of engagement which enters into the pelvic cavity is constant for all flexions and deflections of the head. So, it is fixed. It does not change, but this vertical diameter of engagement changes. That is why you must remember, when the head is well flexed, it is vertex. When it is deflexed, it is also vertex. But the anterior portion is comes in the picture. What happens there? There suboccipitofrontal diameter is the diameter of engagement, well flexed head, suboccipitobregmatic diameter. Suboccipitobregmatic is 9.5 centimeter, suboccipitofrontal is 10 centimeter, it is little more. So, what happens here exactly is, let us see on the board, with increase of flexion, the lesser diameter of engagement will be there, that is, initially it was suboccipitobregmatic 9.5 centimeter, frontal 10 centimeter initially when it is not well flexed, frontal it is 10 centimeter. If it gets well flexed, then suboccipitobregmatic. So, it is 9.5 centimeter. So, it is lesser than this 10. That is why initially there is, from deflection there is increase of flexion and lesser diameter becomes diameter of engagement and it enters into the pelvic cavity. Means what? In these cases, let us pay attention here. In these cases, when it is well flexed, then only it enters into the pelvic cavity. Initially it was floating, then occiput enters the pelvic cavity, then whole of the biparietal diameter enters, it descends up to the ischial spine and head sinciput is not palpable per abdomen. So, that is how with increase of flexion there is engagement. So, what is the first thing which is there? Floating head, then fixed head when occiput enters, when biparietal diameter also enters is engaged head. This is what engagement occurs. What is the result? Engagement occurs here. So, with the increase of flexion there is engagement. What level it occurs? At the pelvic brim. What level the head descends? Up to the zero station or ischial spines. Now come to this second movement. Remember, whenever anything has to enter into the pelvic cavity, it should enter in the epidiameter. Anything has to come out through the pelvic cavity, it should come out in the epidiameter, because all the diameters of inlet, midplane and outlet are more than 11 centimeters this side. Hence, it must rotate towards the midline. Okay. So, what exactly happens here? Let us learn. Second movement in vertex presentation is internal rotation of what? Occiput. Just remember, all these steps are described in relation to the occiput. Hence, wherever the occiput goes, we say there is increase of flexion, there is internal rotation, there is crowning, there is restitution. Wherever we stick up to the occiput only, where it is going, whether it is going internally, whether it is going externally, that is all we describe in relation to the occiput only, because the leader or the leading part is the occiput. So, what do you see here? There is internal rotation of the occiput. With that, from oblique diameter, internal rotation is there and occiput comes below the pubic symphysis here. In these cases, when there is internal rotation of the occiput, just see here, internal rotation of the occiput, there is twist at the neck. Where it occurs? It occurs on the pelvic floor, that is in second stage of labor. When the head descends on the pelvic floor, that time internal rotation occurs. Why it occurs? Because the occiput touches the pelvic floor or levator ani, and lateral and posterior segment of the levator ani, they push the occiput towards the midline. It does not get over rotated towards the other side, because the other levator ani prevents their movement. So, by that time, at the end of this thing, the occiput is below the pubic symphysis. This is known as internal rotation. What is the result of this? From oblique diameter, the head is moving towards the midline. That is why there is twist at the neck. This twist is there. So, remember, with the internal rotation, there is twist at the neck. So, this twist at the neck results. Now, the descent is again occurring down, down. Here, the birth passage is like this. Here is the pubic symphysis. It is downward horizontal and forward. So, it is J shaped. Birth passage is downward, horizontal and forward. So, when head has to rotate, it will come down, then it will come horizontally, then it will come forward direction. So, in these cases there is movement of extension, means the head was like this, it gets extended, then there is crowning, the head gets borne out after crowning. So, what part of the head will come out first? First vertex, then brow and then face. In vertex presentation, vertex will come out first at the introitus. So, here is the introitus, vertex, brow and face will come out. So, in that sequence you must say in the examination vertex, brow and face is borne out. So, the head is borne out by the movement of extension. This is the movement of extension. This is flexion, this is head gets borne out by the movement of extension, vertex, brow, face. Now, once the head is outside the introitus like this, outside the introitus, it was like this, it gets borne out. The moment it is out of the introitus, there is undoing of the twist, that is known as restitution. That movement of the head is known as restitution. Okay? So, here there is restitution. Now, we have said, we have understood the whole of the head is out along with the neck. What part is left now? Shoulder. So, just pay attention in this pelvis. The shoulders are in the one of the oblique diameter. The shoulders are in this diameter. Head is already out of the introitus like this. Now, this shoulder touches the pelvic floor and there is internal rotation of the shoulder. I told you whatever part of the fetus comes out, it should come out in the AP diameter only. It cannot come out in the oblique. It cannot come out in the transverse also. It has to rotate below the pubic symphysis, then only it can come out. So, naturally there is internal rotation of the shoulder, but it results into external rotation of the occiput. Just pay attention to this point. Here is the occiput, there is internal rotation of the shoulder, the occiput is going away from midline. So, I will say there is external rotation of the occiput, it occurs due to internal rotation of the shoulder and the shoulder is borne out. Once it gets internally rotated, then there is external rotation of occiput. Why it is there? Due to internal rotation of the shoulder. And shoulder is borne out, the trunk and the lower limbs follow by the movement of lateral flexion. So, because the obstetric axis, this axis is J shaped, naturally the trunk should get out by the movement of lateral flexion. Let us say the steps here. Initially, there is the descent is occurring throughout the labor. We will say like this. What are the 5 points you should utter in the examination, practical examination? These are the descent is occurring throughout the labor, first point. Second one, you will say there is increase of flexion and engagement. Second movement is internal rotation of the occiput with the twist at the neck. Next, the head is borne out by the movement of extension. During that movement, there is crowning where vertex, brow and face is borne out. Okay. When there was a twist at here by the movement of internal rotation, that undoing of the twist results into restitution. That movement is known as restitution. Lastly, there is external rotation of occiput due to internal rotation of the shoulder. Shoulder is borne out and the trunk and the lower limbs follow by the movement of lateral flexion. Let us repeat it again. Descent is occurring throughout the labor. First movement is of increase of flexion and engagement. Second movement is internal rotation of the occiput with the twist at the neck. Thirdly, there is extension of the head, vertex, brow, face is borne out. Fourth one is the undoing of the twist at the neck, that is restitution. And lastly, external rotation. Last is externally, it occurs externally. That is why remember external rotation of occiput due to internal rotation of the shoulder. Shoulder and trunk are borne out and then there is lateral flexion of the trunk and comes out. This is how the mechanism of labor is described in vertex presentation. Now, let us see the slides over this so that diagrammatic representation is clear to you. Now, let us go ahead with the slides. Hello, so what shall we do now? Let us focus on the slides on the important points which we must understand before describing the mechanism of labor. So, what is that? The first point is leading part. Leading part is different and denominator is different in different presentations. However, in Vertex, the denominator and the leading part, they are same. So, what is the leading part? It is the part which first touches the pelvic floor and there is internal rotation of that part. That is the leading part in labor. So, internal rotation occurs in second stage of labor on the pelvic floor. The denominator is a fixed point on the presenting part. In relation to the pelvic brim, we describe the different positions, whether it is anterior position, whether it is left or right, whether it is transverse position, left or right, whether it is posterior position, left or right, like that. So, denominator is the term given to a fixed point. So, in the leading part and the denominator are same in Vertex presentation, they are occiput. So, let us pay attention to occiput only. First movement is increase of flexion. With the increase of flexion, the lesser diameter of fetal head enters into the pelvic cavity. Hence, the flexion already there is a head is well flexed, but here there should be increase of flexion. When the head is flexed, it enters into the pelvic cavity. If it is deflexed, the larger diameter of the head, that is suboccipito-frontal diameter, 10 centimeter is there, but with increase of flexion, smaller diameter enters into the pelvic cavity, that is suboccipito-rhegmatic diameter, it is 9.5 centimeter. So, with that there is engagement of the head. What do you understand by engagement of the head? Head enters into the pelvic cavity, the biparietal diameter. It enters at the pelvic cavity. Up to what level it enters? Up to the ischial spine, and abdominally the sinciput is not palpable. When the head is well flexed, occiput is at a lower level and sinciput is at a higher level. Okay. So, the next movement is, second movement is internal rotation of the leading part. So, what is the leading part here? Occiput. So, what part will rotate? Occiput. With that, the occiput will be below the pubic symphysis. What do you understand by internal rotation? When the occiput or the leading part moves towards the midline is internal rotation. When the occiput or the leading part moves away from midline is external rotation. So, what is external rotation? Where it occurs? It occurs externally outside the introitus of the leading part. We describe it, this movement occurs due to internal rotation of the shoulder, but still we describe the mechanism in relation with the leading part, that is occiput. We say there is external rotation of the occiput due to internal rotation of the shoulder and shoulder gets blown out. So, that is how the internal rotation and external rotation you should understand. The next is well flexed head, suboccipito-rhegmatic diameter, it is 9.5 centimeter is less. When it is deflexed, larger diameter is there, that is suboccipito-frontal, it is 10 centimeter, 10 centimeters from subocciput to the anterior margin of anterior fontanelle, and this one is from subocciput to the highest point of vertex. So, that is the difference between the two diameters. Initially, when the head is deflexed, suboccipito-frontal diameter is there. With increase of flexion, this diameter becomes the diameter of engagement and it is easy for the head to enter into the pelvic cavity. So, that is why the increase of flexion is important in these cases. Now, you understand there are 8 different segments in the inlet, pelvic inlet. Whenever the occiput or the leading part is towards the anterior part, but on left side it is LOA. You may say VLOA or LOA, left occipito-anterior. If it is on right side, I will say right occipito-anterior. So, this segment is anterior segment. Now, this segment of the pelvis is posterior segment. This is right oblique diameter. The one oblique diameter which starts from right sacroiliac joint is right oblique. The one which starts from left sacroiliac joint is left oblique. So, it goes like this. So, this is left oblique, this is right oblique. In cases of vertex presentation, vertex left occipital anterior position. The occiput is in relation to this, sagittal suture is in this. However, the shoulders are in the opposite direction. So remember, just remember the occiput. The position of occiput will decide whether it is anterior or posterior, whether it is left side or right side. So this is the commonest position, anterior position, and VLOT is the commonest transverse position. VROP is the commonest posterior position. I will repeat again. Here, anterior position is vertex left occipital anterior, transverse commonest position is VLOT, vertex left occipital transverse, posterior position is vertex right occipital posterior position. So just remember these things. Now, when the occiput is here, when there is internal rotation, it rotates through 1/8 of a circle. When its occiput is in the transverse diameter, it rotates through one part, second part, 2/8 of a circle. When occiput is here, it will rotate 3/8 of a circle, one part, second part, third part. So long internal rotation of occiput will occur and then vaginal delivery will result. So this is what is known as internal rotation. Where it occurs? It doesn't occur at the brim. However, this brim I have shown to show it which oblique diameter it is, but it occurs on the pelvic floor below, on the perineum, limit ani. So it is in the same direction, that is why we describe in relation to this. So here there is internal rotation occurring in the second stage of labor after full dilatation of cervix. So that is what is internal rotation. For MCQ purpose, remember the commonest transverse position is 40% LOT. The commonest posterior position is ROP, 8%. This is left is 3, posterior is 3%, this is 8%. So remember like this 3, 8. Now here 40% commonest position, vertex present position. This is position we described. This is 24%, LOA 15%, this is however little less. 10%. So this is how the position is described, position of the occiput. So all the positions, they are described in relation to the central axis of the spine, the vertical line. Okay. So what is this? It's a diagram showing this is normal position and vertex presentation. Okay. And this is abnormal position. Abnormal position means occiput goes posteriorly, is abnormal position because it is described as abnormal because long internal rotation is required in labor, 3/8 of a circle. That is why it is abnormal position, not a presentation. This is normal position, anterior position, transverse positions are described as normal position. Now, this flow chart you must remember whenever in the practical examination you are asked describe the mechanism of labor. Now, all these steps you must utter in the examination. It is very easy to remember with the word fire. Okay? F-I-E-R-E. You have to misspell it. Instead of F-I-R-E, you have to say E-R-E. F-I-E-R-E, like that. Okay? Descent and engagement results. Descent is occurring with that engagement results. Now what next is, first movement is increase of flexion and engagement. Second movement, you just remember second movement is internal rotation of the occiput through 1/8 of a circle with the twist at the neck. You must utter there is a twist at the neck with the internal rotation. Next, what will happen? The head will descend down. Descent is occurring throughout. Crowning results and the head is borne out with the extension. First vertex proface. Next is restitution, that is undoing of the twist. Lastly, external rotation of the occiput occurs due to internal rotation of the shoulder. Shoulder is borne out, trunk and lower limbs follow. So in these cases, I may describe it again shortly for you. So just show it like this in the examination. This way you show it. There is increase of flexion and engagement. The head enters into one of the oblique diameter. There is internal rotation of the occiput with the twist at the neck. That is second movement. The head is borne out by the movement of extension. So crowning, extension means vertex is borne out. Vertex, brow and face. So once it gets borne out, there is undoing of the twist, that is restitution. Lastly, there is external rotation of the occiput due to internal rotation of the shoulder, shoulder gets worn out, trunk and lower limbs follow. This is how you must describe the mechanism of labor in the practical examination once this pelvis and fetal skull and dummy is given to you. That is all, very easy. We will not forget, just remember for posterior position there is just long internal rotation of the occiput, that is all. First is decent engagement, that is understood, flexion, internal rotation is second movement through 3/8 of a circle, crowning, then extension where vertex, brow, face. Restitution, lastly external rotation of the occiput due to internal rotation of shoulder, shoulder is worn out, lower limbs and trunk, trunk and lower limbs they follow by lateral movement of trunk. Okay, that is all. Thank you so much for the patience.